Evening again, brothers and sisters. We are about to make a start. I am Judy Benoit, your moderator for this afternoon session. And to begin with, I invite Mr. Dennis Thomas to lead us in a word of prayer. David, sorry, sorry, Mr. David Thomas, yes. Yes, you could take it from there.
Let us all reverence God in our midst. Almighty God, great and glorious you are. No one is like you, O God. And in your presence, we acknowledge our sinfulness. You, our Creator. You have allowed us to be gathered here for your glory, your honor, beyond our understanding. So be present in this gathering, O God Almighty. Work your way in us as only you can.
And on some very important topics. As we know, in Grenada, the only thing that seems to keep us indoors is rain. And so we sort of expected a small turnout, but I think the many of you who brave the weather, we welcome you very much, and we are happy that you're here. The important thing is that once you get the room, it's just down the steps right here. Those with cell phones, please, we would ask that you keep it on silent or on vibrate so that you don't disturb. You can slip out easily and take a call if you must. Okay? And just to give you the order of the presentations this evening, we will start with managing non-communicable diseases. That will be done by Dr. Devron Joseph. He will also give you probably a little introduction as to the entire session. Then we'll have screening, cancer screening by Dr. Oyeronke Alexis. We'll have men's health by Dr. Azel Baptiste, and children's health by Dr. Taisha Donald. Each of these doctors will tell you a little something about themselves before they get started. We will allow each presentation to go. I hope each one walk with a phone or a pen and paper to make notes in terms of what questions or comments you would want to make, and we will hold all the questions and comments and so on, and answers, of course, for after the presentations. We wouldn't want to take them in between and then the last doctor doesn't get to say much. So we take all of it and then the questions and answers. So without much further ado, I would ask and invite Dr. Devron Joseph to begin his presentation, and he is going to speak with us on managing non-communicable diseases. With a lusty round of applause, please welcome Dr. Joseph.
And pressure, or hypertension, right, is a very, very common disease. What's considered normal blood pressure is systolic blood pressure of 120, less than 120, and a diastolic blood pressure of less than 80 millimeters of mercury. Right? These are values that we manage, and as a general community, you should understand what it is as normal blood pressure. It's considered hypertension from values that are persistent and without any precipitating cause of systolic blood pressures equal and above 130, and diastolic pressures equal and above 80. Right? When it gets to figures such as 140 and 90, these are different stages of the disease which can indicate worse disease. Right? These are things that will be managed by your physicians, but just to know these are the values that you want to be looking for when it comes to your blood pressure. It's a very common disease. Worldwide, it was estimated in 2019 that 1.3 billion adults would have had diabetes. Considering global populations was around 7 billion, this is like a 1 in 6. So if you were to even check on statistical data, meaning every 1 you check every 6 persons, at least one of them would have had hypertension or high blood pressure. Right? The prevalence, meaning it's more common in males, older adults, and in black individuals, right? Persons of Afro-Caribbean, Afro-American descent. Some major risk factors include persons of older age, obesity, having a family history, meaning you have like first generation siblings and you have your mother or father or aunt that have that high blood pressure that runs in the family, you have a risk of getting the disease, right? Like I said, ethnicity is more prevalent in blacks, high sodium diets, high diets that are filled with salt and excessive drinking and alcohol consumption, also a major risk factor. Smoking, whether it be marijuana, cigarettes, or combination of both, and physical inactivity. Sedentary lifestyle, no regular activity or exercise that in your daily lives. So what are the signs and symptoms? So predominantly, what we understand, the main sign and symptom is that there isn't any. That's the most common sign and symptom. None whatsoever. So persons are walking around here with blood pressures that are elevated, damaging their major organs, and they have no clue because they feel fine. Some other signs and symptoms may include things like blurred vision, nosebleeds, dizziness, severe headaches, and sometimes difficulty breathing when these diseases affect the heart. But these are usually less common. More often than not, you don't feel anything and you're walking around with these elevated blood pressures. So how do we diagnose? Right? Diagnosis is made by your physician or healthcare professional. That's usually, in our setting, is usually office-based blood pressure monitoring, right? Where the physician, over a series of blood pressure readings, would have consistently seen that your blood pressure is above normal and that you're considered hypertensive, right? There are other diagnostic modalities, including ambulatory blood pressure monitoring, where you strap on a blood pressure monitor on for 24 hours. We don't usually, it's not very common in our setting on island. And home blood pressure monitoring, where your doctor would send you home to check your blood pressure readings with your automated machines, right? And then based on your average readings can determine if you're hypertensive. Right? Once you've been diagnosed with high blood pressure or hypertension, your physician will do an evaluation. Right? He will do a physical exam, we check your heart, we check your lungs, we check a full physical exam to see what's happening with you, and then order investigations, which will include some blood tests and maybe some imaging depending on what he finds. Right? A renal function test to check for your kidneys, because we want to know if the blood pressure has been damaging your kidneys. Fasting blood sugar or blood glucose, because we know that hypertension and diabetes seem to walk hand in hand, so we want to screen for these things. Check your urine to see if there's issues that indicate that there's a problem going on with the kidneys as well in your urine. Check to see if there's proteins indicating to us that they're kidney disease. Complete blood count, which will check your overall blood level. Check on your thyroid with thyroid tests, because often thyroid disease might be implicated in high blood pressure. A lipid profile that looks for your cholesterol, which has bearing on what in high blood pressure and its exacerbating factors. And electrocardiogram, which checks on the health of your heart. Right? These are tests that your doctor would order to see how long you've been hypertensive and if there's damage to your organs already. So, hypertension, many know it as the silent killer, right? You don't know that you have it until you've experienced complications, right? One of the common complications that you have from high blood pressure is strokes. It damages the brain, you get a stroke, you lose the ability to speak or use half of your body or a certain set of your limbs, right? It can, right? Your blood pressure acts like a weight that your heart has to push against, and it decides to push against that high pressures, it needs to get bigger. It needs to exert more pressure. And eventually it gets bigger. It seems, like that makes sense. I want my heart to get bigger and stronger. But what really happens is that as it gets bigger, the cavity that has all the blood gets smaller, and it's not doing an effective job and could end up in something called heart failure, where your heart is no longer aggressive, just to be less than 140/90. Then we start off with lifestyle modifications. Your life needs to change before we even think about moving on. Your diet has to have reduced salt intake, and what example of a good diet if you're obese. Exercise, you introduce, meaning you need to stop. Do not smoke anymore, right? Lastly is your medications. Some of you who are hypertensive may already be familiar with these medications, right? There's whole groups of medications that your physicians would be aware of, and based on your specific risk factors, your physician would decide which medication is best for you to start, right? So combinations of these medications would be the next step in controlling your disease. So moving on to type 2 diabetes, right? Diabetes, again, everybody and their grandmother has diabetes. It's also a very, at least in the early stages, right? It's not as, the lack of symptoms is more prevalent in hypertension, even though it is common in diabetes. But diabetes also has other signs and symptoms, right? One including excessive urination, right? We're not talking about one day. Yes, we're not talking about one day of just having to pee over and over and over. We're talking about you notice abnormally that you're going to the bathroom more frequently, associated with excessive thirst. You're drinking lots of water. It's not particularly hot. You continue to drink more water. You continue to urinate, and it seems abnormal to you. Other signs would be including excessive hunger, where you continue to eat and you still don't feel satisfied, associated with weight loss, fatigue, blurred vision, and frequent skin abscesses. Right? All of these can be signs that you have diabetes. Right? Our target blood sugars are daily finger sticks or blood sugars with your glucometer at home should be under 130 milligrams per deciliter before meals. So when you're fasting as a diabetic, that number should be less than 130. Just before you have lunch, that number should be less than 130 to see if your blood sugars have been controlled. Because what has been shown statistically is that the higher values of A1Cs have been linked to higher incidences of complications. So you lower your A1C, the better you are with your diabetes, and you reduce your chance of complications. Moving on, lifestyle modifications, similar to high blood pressure. Nutrition, dietary modifications, you need to, as a country, we eat a lot. I was chatting with a friend, and we were discussing how much we eat, right? Somebody's born, we eat. Somebody dies, we eat. We're celebrating anything, we eat, and we eat lots of food, right? The food that we mount on our plate makes a canopy that is way too much food, right? When we talk to a dietitian, you realize that we are able to sustain ourselves on way less food than we eat on a daily basis, right? So all of that needs to be done with your nutritionist to modify your diet. Weight reduction, all of that helps with your blood sugar control. Exercise, similar to your hypertension. 30 minutes a day, 5 days a week of moderate intensity, brisk walking. That can be modified to things like if you have high intensity exercises, like if you're someone who runs, or if you're someone who goes hiking, or some high level intensity type of exercise, then that number could be 3 days a week. but the overall recommendations are at least 30 minutes, moderate intensity, 5 days a week. Right? Limit your alcohol in R and Lantus and Apidra. These are the options that we have to treat our diabetes as prescribed by your physicians. Right? So I have some take-home points that I know I went a little bit quickly, but we have like 3 more presenters, so I cannot take up all the time. So the main things I want you to take away from this presentation is to understand that diabetes and high blood pressure or hypertension are 2 non-communicable diseases that are chronic. They require long-term management. There is no cure, right? Meaning that you manage this disease every day of your life with diet, exercise, weight loss, and your medications that are prescribed by your doctor, right? Major risk factors include things like obesity. If you have family history, someone in the family has diabetes, has high blood pressure, you're at risk. You have to look for that. Ethnicity, right? You're a black individual, you're at risk. If you don't do exercise, physical inactivity, if you have poor diet, right? If you know that every night you're ordering, fried chicken from the lady down the road, you know who you are. You have toxic habits, meaning excessive alcohol intake, and you know who you are. If you smoke, whether it be marijuana, cigarettes, or a combination of both, again, you're at risk, right? Often, these diseases have no signs and symptoms. So you feel great, you feel okay, you feel like you can take on the world, and your blood pressures are through the roof, your blood sugars are through the roof, slowly damaging your organs, your kidneys, your heart, your brain, all right? If you have diabetes and high blood pressures, you need to set targets with your doctor and try to meet these targets daily, right? For your blood pressure, one example, less than 140/90 may be your target goal. It might be different depending on what your physician might recommend. For your finger sticks, less than 130. Before meals, your A1C, you want it less than 7 to be controlled, right? Finally, lifestyle modifications and daily medication compliance. Do not miss your medications. Your medications, if it's one thing I see every day, is that person's telling me, well, it finished. No. Even if the last week of your medications, you need to get it refilled because these medications are for life, right? Your diabetic medications are for life. Your hypertension medications are for life, right? Unless your doctor modifies your treatment, okay? So we need to establish lifestyle modifications and daily medication compliance, which are essential to be able to meet your targets and subsequently reduce the chances of heart disease, kidney disease, and many other complications. Any questions? No? Wonderful. No, okay, I'm just playing. Are there any questions? Oh, okay, questions after? Okay, wonderful. So I'd like to end with a quote that I thought fit in. I believe it's by Buddha. I'm not sure. But it says, every human being is the author of his health or disease. Yes, I know physicians, we play a very active role in your health care, but you need to be the most invested in your outcome, right? You're the one that needs to put in the work, and we're here to help. All right? Thank you very much. I hope this was productive.
Thank you, Dr. Joseph. I think he was really profound and easy to understand. For the last 2 years maybe, we were hearing solely about So while we wait, I want you to keep reflecting on the messages we had from Dr. Joseph. I know people have questions, and as I said before, write it down and make sure at the end we're going to take all instead of in between. So now to Dr. Ali.
This evening, I'm going to be presenting on cancer screening in Grenada. Early detection saves lives. Now, mortality trends or the causes of death in Grenada, according to the World Health Organization 2019 statistics, the leading causes of death in Grenada were ischemic heart disease, as we've just heard about, stroke, diabetes mellitus type 2, infections of the lower respiratory tract, and in fifth position, prostate in high-income countries due to lifestyle factors of smoking, obesity, and alcohol intake. And breast cancer is the leading cancer type in females in most countries around the world, and also in Grenada, as we just saw. For instance, among the top 10 countries with the highest cancer rates per 100,000 individuals in 2020, Australia had highest rates of malignant melanoma, which is skin cancer, that's common among them where they are exposed to the sun, and also breast cancer. Now, while breast cancer mortality or death rates are declining in many of these high-income countries, they continue to increase in countries where traditionally there were lower rates of breast cancer, and that would include Grenada. In lower resource settings, breast and cervical cancer disproportionately affect women in the prime of life, resulting in significant economic and societal impact. The risk factors for breast cancer are age. Most of these occur after the age of 50. There is some genetic contribution in certain populations. There are genes that can be identified, the BRCA1 and the BRCA2 genes, which give a higher risk of breast and ovarian cancer. Now, even if you don't have those specific genes, there are other genetic risks, such as having first-degree relatives, sisters, mothers, and with breast cancer, or multiple relatives with breast cancer. And this can also include male relatives with breast cancer. Other risk factors would be prolonged exposure to estrogen, which is the female reproductive hormone. And this occurs with early menarche, early age at first menstrual period, late menopause. If you use hormone replacement therapy to go through menopause, that increases your risk. Oral contraceptive pills, first pregnancy after age 30, not breastfeeding. Other factors would include obesity and lack of physical activity. So breast cancer screening can involve a self-exam in which you inspect your breast for skin changes and feel for lumps. But this is of limited effectiveness clinically. Breast ultrasound can be used for teenagers with dense breasts, particularly if they feel any changes. The gold standard is the mammogram. Radiation exposure. Now, one chest X-ray will give you a certain dose, 0.1 millisieverts of radiation exposure, and in comparison, a mammogram will give you 0.4 millisieverts of exposure. That's just about 7 weeks worth of background exposure. So it's not much more than a chest X-ray. And it certainly is far less than a CT scan of the chest, which will give you 100 to 800 times the radiation dose of a chest X-ray. And another risk of screening is that you may have false negatives occurring as 1 in 8, and you go away reassured when you do have breast cancer. So the Centers for Disease Control, they have summarized the breast screening guidelines in the USA. There are 2 voluntary organizations that have laid these out: the United States Preventive Services Task Force and the American Cancer Society. So the USPSTF, they are recommending that women aged 40 to 49 with an average risk can take an individual decision to have their mammograms. If they want to weigh the potential benefits and the potential harms, and they decide they want to go ahead, they may. The American Cancer Society is saying similar things for women aged 40 to 44, but they do recommend a screening for those 45 to 49. So So you see it's in the mid-40s that they're looking to start screening. The Preventive Services Task Force, they're saying that between the ages of 50 and 74, you definitely should have the screening mammography every 2 years. The American Cancer Society, they're saying that between the ages of 50 and 54, you should have annual screening. And after age 55, you should have the screening once every 2 years. Now, colorectal cancer, we saw that also has a high incidence here in Grenada. And generally, it's seen among people ages 65 to 74 years. However, there has been increasing incidence in people under the age of 50. So that's 10.5% of cases. And there has been a 15% increase in incidence in people aged 40 to 49 in the USA. In that last period there, 2014 to 2016, as compared with 2000 to 2002. So screening gives you the best benefit between the ages of 50 and 74. The benefit is more moderate at a younger age, 45 to 49, and for people over the age of 75 there, the benefit is only small. So 50 to 74 is where you should focus on screening for colon cancer. How do you screen? There's a blood test, the CEA, which is the carcinoembryonic antigen. It's testing for certain proteins that you would find on cancer cells. And you can test the stool itself, fecal occult blood test. You're looking for blood that is hidden in the stool. And this can reduce colorectal cancer death significantly. There's a newer test, the fecal immunochemical test, to also detect blood. It's a bit more sensitive. And then there are the direct visualization tests, such as colonoscopy, in which a sort of long tube is inserted into the back passage. It's attached to a camera, and you do that test every 10 years. This has the greatest impact on life years gained per 1,000 individuals screened. It allows you to directly visualize small cancers before they give any signs of being there. So the United States Prevention Services Task Force, this group of specialists, they recommend colorectal cancer screening starting at the age of 45 years. And for older adults, you should individualize your choice if you think you have a higher risk than normal, than average. So as we're seeing here, estimated life years gained are highest for the direct visualization test in all age groups, more so than the stool test. Prostate cancer screening, they're offering two modalities. The blood test for the PSA, the prostate-specific antigen, looking for a protein that's present on cancer cells and which increases when you have cancer of the prostate, and the digital rectal exam. Digital means fingers, so the doctor uses his or her fingers to feel the prostate through the rectum, through the back passage. And the American Cancer Society is recommending screening from the age of 50 years with those of average risk of cancer. From the age of 45, you should start screening if you have a higher risk, and that higher risk is if you are an African American or you have a first-degree relative who was diagnosed with prostate cancer under the age of 65. And you should start screening from the age of 40 if you are at highest risk, and that would be more than one first-degree relative diagnosed under the age of 65. And what the statistics show is that Afro-Caribbean males are at even higher risk than the African Americans. So they would want to start screening from a very young age, there, age 40. This screening is only for people who have a general life expectancy of over 10 years, because many prostate cancers are slow growing. So the cutoff for the PSA is less than 4 nanograms per mil. For values between 4 and 10, there is a 25% chance of prostate cancer, and that increases to 50% chance if the PSA value is greater than 10. So how can you really decide what's going on? Is this just an enlarged prostate, or is it cancer? Another helpful approach is to test the percent of free PSA. And if it's less than 10%, if most of your PSA is bound to protein in your blood and less than 10% is circulating freely, then you have a higher chance of cancer and you would need to arrange for a biopsy. A newer approach that is available is the 4K score test, in which you measure the total PSA, the percent free PSA, the intact PSA, that is PSA that has not been broken down, and the human kallikrein protein, which is another protein found on the prostate. And you combine all of that information with the patient's age, with the information from the digital rectal exam, and from any new biopsy results. And this can help to tell whether someone who has prostate cancer can have a wait and watch approach, because there is a lot of sort of low-grade or mild cancer, as opposed to someone who has more aggressive disease at the time of diagnosis. So this is not to be used on patients who already have a diagnosis of prostate cancer. Why is it important to catch prostate cancer early? Complete cure is possible once the cancer is still confined to the gland, stage 1 or stage 2 disease. You can have radical prostatectomy, in which you cut away the prostate, or radiation for a high-grade tumor. And then your 5-year survival is going to be nearly 100%. In stage 3, the cancer begins to break through the capsule or the lining of the prostate, and the 5-year survival rate falls to 95%. By stage 4, where it has spread either to nearby organs, such as the bladder, or to distant sites, such as the lungs and bones, 5-year survival falls to 50%. So PSA screening is effective and saves 7 lives for every 1,000 persons screened. As we said, Afro-Caribbean men have a higher risk of prostate cancer than any other population of men in the world. This is according to SAGE journals. Prostate cancer is the leading cause of cancer-related death in the Caribbean, with the highest prostate cancer mortality in the world. And when they looked at the Caribbean nations, they saw that every single nation except for the Turks and the Caicos had a higher age-adjusted mortality rate than the USA. And as they compared the Caribbean black population with those born in the United States, blacks of the United States, black Caribbean and Hispanic Caribbean blacks had significantly higher mortality rates for prostate cancer. We have an example here. St. Vincent and the Grenadines and Montserrat both had mortality rates of 115 men per 100,000 of the population. Then there was Dominica with 91, and Grenada close after with 90 per 100,000. Again, this graph shows that the incidence of prostate cancer in the Caribbean is much higher than, let's say, the Europeans and the other people. Prostate cancer incidence and mortality figures by continent. Now, the blue graphs represent here incidence. So you see that because of widespread screening, systematic screening in very developed countries, you have high incidence here, but the mortality is low, okay? So in America and Europe, and so the mortality from cancer of the prostate gland is low. Compared with the Caribbean, which is leading the world in prostate cancer mortality, the incidence is not as higher as here, but the mortality rate is strikingly high. It's a death sentence, that there is nothing that can be done. Whereas we see if it is picked up early, it can be treated. Cervical cancer screening. Now, the UK recommendation is that women should be tested for human papilloma virus infection. This is the virus that causes cervical cancer, cancer of the neck of the uterus. And once they test positive for this virus, then they do a pap smear, and the pap smear is going to search for abnormal cells, cells that may be cancerous, and then go on further for colposcopy, that's further investigation and examination of the cervix. They offer screening every 3 years for women aged 25 of discomfort and distress. It went back, yes.
Thank you, Dr. Alexis. I am sure that those who came, glad you came. This information that we just got from Dr. Alexis is really revealing. And I really hope that when we leave here, you'll realize that we have a lot of work to do on ourselves. I will now invite the gentleman who is at the laptop, Dr. Azel Baptiste, and all the men in the audience, please raise your hand. Right. Okay. He wants you forward. He has the message for the men. So he is going to speak to us on men's health. Give Dr. Baptiste a round of applause for that.
I work at the general hospital, but I work at the surgical department. And I particularly work with in the urology department, with the urologists. All right? Some never myself. I like medicine. Prevent it. A lot of the things are preventable, and we don't have to wait until the disease come upon us for us to go to the doctor. I believe in preventative medicine. Prevent it, as the old people say, that ounce of prevention is better than a pound of cure. All right? So let's move on. Just give me a second, please. Sorry. Intermission. Let me see. Yeah, that's. Like they try to sabotage me, or I want to believe they try to sabotage the men here. I'm just kidding. Okay. So I took this excerpt from a journal that was done in Ireland, and it says it is against particular norms of masculine behavior that men must constantly negotiate their own behavior in relation to how they manage their health. All right? What does that say? What does that say? The thing is, we have been cultured in such a way, and I'm talking about in different societies, you look at the UK or the Europe, you look at Africa and so on, that boys have to be manly, and boys have to be strong, and boys not supposed to cry. You have certain statements like, big boys don't cry. You heard people saying, it's woman, then dog, then man. And we hear a lot of local idioms and so on alluding to those things. Yeah? The truth is that based on our culture and so on, from since before we were born as individuals, we already have this psychology, and not only the psychology, we have this socialization as to how a boy is supposed to be treated compared to a girl. You would see they would have when they would reveal the sexes of the babies, they would have the baby shower, and they would code it. The girls normally get pink, and the boys blue. So we already start, and Dr. Donald is going to tell you about those things a little bit more, conditioning our boys and our girls to act and respond a certain way. So later on when you hear, oh, men don't like to go to the doctor. Men don't like to get health checkups and so on. It's because we would have been already cultured socially to respond in a certain way. All right? So we'll look at, would have highlighted some objectives. All right? The facts about men. And I want us to do a lot of introspection. I want us to think a lot. Yeah? Because that is where it will have to change. Certain things, certain policies and so on that are institutionalized now would have to change. All right, so the facts about men. What is men's health? We look at the risk factors, which is very important, affecting men's health. We look at the primary diseases affecting men's health, and then prevention, screening, and early treatment. A lot of those things were said before, so we won't be redundant, but I want us to look especially about those facts and especially the risk factors, because that is where we have to intervene. If we have to do anything and catch it early, we have to intervene in the different risk factors. So the facts about men. So men are half as likely to see a physician or to see a healthcare provider for a physical examination as a woman. Think about it. We are half as likely to visit a physician. Men are most likely to be uninsured than women. Let me see how much men inside here have insurance. One man inside here have insurance? So we see what we're talking about. Okay? Men are dying at higher rates than women from 9 of the top 10 causes of death. And that includes non-communicable diseases that Dr. Joseph spoke about. So 9 out of the top 10 causes of death, like cardiovascular diseases and so on, men are leading women. Okay? And yet for we strong. We ain't strong at all. Yeah? Men are more likely to die before the age of 70 than women. And the overall life expectancy is shorter. Next. Men have a 7 times greater risk of dying from homicide than women. And that is so true. We look at, maybe not so much here in Grenada, but most of the homicides and so on that take place, especially when you look at Jamaica and Trinidad and the US, talking about in New York, the greater number of persons dying from homicide, whether it be drug-related or whatever the case may be, are men. 36% of death in men is preventable, compared to 19% in women. So it makes me wonder, it makes me ask the question, are we really stronger? Are we really smarter than women? And I think not. We're losing. And it's not a competition, It's not a competition. To define health, I was looking up for a definition for men's health. And it's astonishing that men's health is so complex that up to now they haven't derived a definition per se. You understand? They would have had several summits and so on to come up with a particular definition, to coin a definition, so that the approach to men's health would be a better approach. And up to this day, they can't really put their hand on a specific or one definition to define men's health. So if you look at it, you would find in different countries, they use different definitions. Okay? Based on the WHO's definition, men's health is a state of complete physical, mental, and social well-being, and as experienced by men, and not merely the absence of particular disease. Okay? I particularly liked this definition by Poach and Willis, which defined men's health as the following. Men's health is a holistic and comprehensive approach that addresses the physical, mental, emotional, social, and spiritual life experiences and needs of men throughout their lifespan. So that means that men's health would have started since that boy child would have been born. Okay? And it encompasses every aspect of their life. Whether it be in the church, whether it be in the school, whether it be in the playground, it encompasses all different ambits of their life. Okay? Now we look at some of the factors that we take into consideration when we're talking about men's health. So we have the biological factors. Naturally, when a sperm fertilizes an egg, what happens is that 23 of the chromosomes from the male is passed on, and 23 of the chromosomes from the female is basically contributed as well. But there's one chromosome in particular that determines the biological gender. Okay? It's either X or Y chromosome. If it's a Y, we get a boy child. If it's an X, a girl child. So it starts when the child is born. Okay? So once that child is born, he has male genitalia, and he's considered a boy. Okay? You have also, so that would be the biological aspect of it. And the biological aspect consists of the reproductive organs, different hormones, and so on, based on the biological nature. Things like testosterone. You have the androgens and so on that are high in men, and that is normally lower in female. That is why you get certain specific diseases that affect men alone and not women. For example, prostate cancer. All the diseases that affect the prostate gland. Things like erectile dysfunction, okay, which affect men's sexual health as well. Okay? Other factors are things like the social factors like behavioral patterns, sexual conduct, and so on. All right? So we look at some of the factors still, moving on. So we have the gender-specific factors. And as I said before, those things give you things like prostate diseases, sexual dysfunction, hypogonadisms, testicular and scrotal diseases. There are also the non-specific gender diseases that affect both men and women, but men are still leading the race. Yeah? And also suicide. For every one woman that commits suicide, you have 4 men killing themselves. So that says a lot. You know? And we have to, as I said, do a lot of introspection and go back to the table. Okay? So we have social situations as well, where more women tend to go through school and so on and finish maybe tertiary education and so on than men. We see a higher rate of dropouts and so on in school, in young fellas, in young boys, than women. And all of those factors, the social factors, affect the overall health of men. Almost every accident, I talk about driving or whatever, road traffic accident, or every shopping incident, when they go into parties and so on, is a young man that comes in because he was consuming alcohol. Okay? And that is something that affects us directly as a society here. Grenada has one of the highest rates of alcohol consumption. We drink until I've seen young men, they reach to a state where they basically, in stupor. The stupors, they don't know themselves and so on. Some of them follow and so on. And when they come into the emergency department, they behave bad. They don't even remember. Sometimes the next day when they tell them how they behave, they are so ashamed because they are a completely different individual. All right? And those are the things that we have to start addressing maybe as a society as well. Okay? Men underutilize primary healthcare services, and it's so true. For every 2 women that goes to a physician, 1 man goes. Sometimes we stay until the disease advances and basically crippling us before we decide to go to a physician. I have the instance, I have an encounter today that a gentleman's foot, and he's like about 35, his foot is basically rotting on him. And then they have to get a physician to go to the house, that's his dad, to see him because he wasn't going to the doctor. You know? With a female, if she toenail hotter, she only go to a physician. Yeah? If she have a bump on a middle finger or a little finger, she would go to the physician. And that is something that has to change, because sometimes because of the culture that we have, that we're manly and we have to be strong and we have to resist certain things, we tend to go to physicians and so, right? Men tend to have a lot reckless drivers. The majority of reckless drivers are men. And we see that from time to time in our society. A lady taking she time going down the road, and a bus driver or whosoever just come. What are you doing there in the middle of the road? And they just get on with the road rage and so on. Most of the accidents and so on, that road traffic accidents, are because of reckless driving, and they're more predominant in young male. Right? The older drivers tend to drive a lot with a lot more experience. Most of the road traffic accidents, and we'll see that just now, is below the age of 20 years. And it's a pity that we don't have any young males here tonight, because they should be hearing those things as well. Men tend to have risky sexual behaviors, from multiple partners to not using contraceptives and so on. They tend to be a lot less careful, or a lot careless than women, right? High-risk sports. We now get engaged in the football, the basketball, and so on, where you have a lot of contact sports and so on. So all of those things contribute to our overall health. So these are the leading causes of death in black males, and this was taken from the CDC, a 2018 report. The principal cause of death, as we would have mentioned before, are related to heart disease. Okay? So cancer is the second leading cause of death. Then you have things like Alzheimer's disease and so on in the older men. Stroke, which is the fourth cause of death. And then you see 5, homicide. And this was taken, mostly a study that was done in the States. So I'm not sure if it's the same thing here in Grenada. All right? The leading cause of death by age groups. And I just want to point out those things. From 1 to 19 years, we have the leading cause of death being homicide, and then the second leading cause of death being unintentional injuries. All right? Those things are important because that is where we are the target. If we have homicide and unintentional injuries being the leading cause of death in men that are, let's say, 1 to 40 years, then we have to start targeting and maybe putting different measures in place. A lot more safety measures, a lot more harsh punishments and so on have to be undertaken. All right? And then from the 45 to let's say 100 category, we have heart disease, we have cancer and so on being the leading cause of death. There's stroke and so. Those things are important because we need to know where the larger the risk factors are to address it. This is a graph that shows the rate to the rate of suicide, but all of the to the rate of suicide, but all of those things we have to consider as well. All right? Men, if y'all get any problems, speak up, eh? You have the opportunity tonight. You can come and tell me. All right? So steps to live a long, start off with a bang. No. Take your time. If you could do 5 minutes, increase it gradually. All right? Try to do it at least 2 times a week. Even if it's just to wash your car, whatever the case may be, because a little physical activity is better than no physical activity at all. Prostate health. And this is important because I work along with a urologist, or the urology department, and it's sad to see how many men are affected by prostate disease, and they wait until it's advanced to come for a little help or assistance. I've seen men they wait until they're crippled, they can't walk, they start with severe back pains and so on, or they reach to the point where they cannot pass urine. So they've been forcing to pass urine for a long, long period of time, and they're just not going to see a doctor. And the day that the urine stop come, and in retention, what you call urinary retention, that's when they come. You have men here wearing a tube in the penis and so on for 10 years, 15, 13 years. And that's not nice. You know, as a human being, as a human, it's not a nice thing. All right? So pay attention to your prostate health. Think some of the signs and symptoms, be aware of it, because it's cancerous and it's already spread to the bones and so on. So all of those things you have to think about. Yeah, as Dr. Alexis would have spoken about prostate health and screening before, those things we have to try to screen early. Anybody, any man after 45 years should get a prostate check. So you get a prostate check, you do the PSA. 15% of the cases are detected. They have normal PSA values, but they're detected by feeling a nodule or so on the prostate. So go get your prostate check. All right? Another thing is consult your care provider about yearly exams after the age of 40. Have regular, safe sex. Regular, safe sex. You know, one partner, and you practice safe sex, because studies have shown that when you're sexually active, or sexual activity is good for your prostatic health. It is what we call a protective factor. All right? So those are the main diseases that affect the prostate. You have prostate cancer, you have what we call BPH. It's something benign, but your prostate gets so big that you can't pass the urine. And you have things like prostatitis that affect more the younger men. All right? And those are linked to, as we said before, sexual conduct and so, when you have an unhealthy sexual lifestyle. All right? The cardiovascular diseases, we'll have seen them before and the steps to take. All right? Things like the hypertension and so on. It's important, again, to have regular physical checks, lose weight, get into regular exercise routine, limit the alcohol, and stop the smoking cessation. All right? Because diabetes is one of the leading causes in men as well, and we saw that Dr. Joseph talked about erectile dysfunction, which is something that affects a lot of men. A lot of men, they are 50-something or 60-something. They have young wives, but they have problems in the home because they have health issues when it comes to their sexual activity. They tend to take the things on their own. They resort to the bottle. You understand? It's very advanced. They take their lives because they cannot deal with it. So it's important to be being feminine. Yeah, we're being soft. Because our culture teaches we have to be boys and we can't cry. It's important to cry. Or it's normal to cry. Okay? So treating depression starts with yourself. Get some exercise, 20 to 30 minutes per day. Spend some time with other people. Do something that you like to do, you enjoy. If it's fishing, whatever the case may be. Dr. Joseph, when he is depressed, he normally go and play pool. Maybe Dr. Joseph? Do something that you like, okay? You prioritize your needs every day. And your needs, okay? A lot of us want a lot of things, but you prioritize what you need. Set realistic goals. Be patient with yourself. Coping with stress and anxiety, exercise, you eat healthy, you don't self-meditate too much, ease up on the caffeine, you try to get 8 hours of sleep, you take deep breaths, you relax, you try to relax as much as possible. All right? I'm sure that we would have seen a trend here tonight, yeah? To see your doctor regularly, to eat healthy, things like food rich in fruits, vegetables, whole grains, low fat, and so on. To exercise 20 to 30 minutes per day, or at least 3 to 5 days a week, sorry. Maintain a healthy weight, get a good night's sleep, manage your stress, all right? And you get professional help if you need it. Because those are the things that would save us a lot of complications, okay? And finally, as I said before, an ounce of prevention is better than a pound of cure. All right, thank you very much.
Well, one doctor told us we eat for everything. Another one tell us we drink for everything. So we forever eating and drinking. But I just want to offer a word to the men. Before you go to the drugstore and buy Hard On Plus, See your physician. I- Okay, so we move down to our final presenter for tonight, and she is none other than Dr. Taisha Donald. She'll tell you a little bit of herself, and she will speak to us on children's health. Give Dr. Donald a round of applause as she comes.
Thank you, and good night to everyone. So I'll start by telling you a little bit about myself. So I'm a daughter of the soil, meaning a daughter of St. Paul's. So I'm from St. Paul's. I'm a pediatrician. I also perform the role of medical director at the General Hospital. So the panel are my colleagues. We all work together. And tonight I'm going to be speaking a little bit about children's health. We're going to be touching on hygiene, nutrition, immunization, basic first aid, managing fever, and the current trends in childhood illnesses. I mean, you see hygiene there and you might be thinking hygiene. We all know about hygiene, but surprisingly enough, as a pediatrician, I realize it is an area that I have to talk about all the time. Just a reminder of what you. But daily brushing of the teeth is a big deal because the dentist will tell you in Grenada there's a very high incidence of dental caries. Teaching the kids washing hands before and after meals. Well, I have to say, because of COVID-19, the hand washing and the hand sanitizing is on point. So all the kids who come into my practice, by the time they reach in, they sanitize. By the time they touch the desk, they sanitize. So I think the parents have done an excellent job in teaching the children about sanitizing their hands, and we just want them to teach them now about hand washing. Now remember the toilet. Always wash your hands after using the toilet. So we have to teach the kids that. The girls, remember, they should be clean from front to back. Now there's a reason for that. Remember, the front is the vagina, pee area. The back is where you tutu, right? Now if you go from back to front, tutu goes right up, right? So you have to go from the front to the back to make sure that you don't contaminate the tutu area with the rest. Yes, because this is how the girls could get bladder infections and even infections around the vulva and the vagina. So we want to be very careful. It feels nice when you're cleaning it, but for the kids like it too, some of them. But what happens is that if, depending on how you use your cotton bud, you push stuff in. You push the wax in deep, and it causes blockage. So what we recommend is that you should clean the outer air with a clean rag. Avoid pushing things in because two reasons. In children, you push things in, they think, oh, that's normal, it's okay to push things in. So after we do the bath, now, Granny would say, put a little BNT powder, put a little ointment. You don't need that. All you need after the newborn baby have its bath, you want to make sure that you soak a cotton ball with some mentholated spirits, and you wipe around it. That's all you need. So it would dry up with time. Within a week or so, it would dry up and you'll be fine. No BNT powder, no ointment. All you need is a little spirits. Now, nutrition. There's a lot to talk about nutrition because I'm doing a different angle. They all talk about the big people and I'm talking about the little ones. I think I'm the shortest in the group too. So in nutrition, now I'm a breastfeeding advocate. All right, I'm big on breastfeeding and I really want this message to go out. So for breastfeeding, now I know back in the day they used to say for 4 months, but for now, it's been a few years now that we've been saying that exclusive breastfeeding is for 6 whole months. But it's not that long, Breast is the best all the time, right? Now, the only time you shouldn't breastfeed in that for 6 months is if the doctor told you shouldn't breastfeed. And there are reasons for that. Sometimes you have some sort of infection that can pass on to the baby. So, for example, in cases like HIV, HTLV, we advise, that they shouldn't breastfeed. But other than that, breast is best all the time, all right? Now, the breastfeeding mother, because we might have some persons in here who have, Missy, I ain't sure, but we might have persons in here who need to maybe tell their friends or themselves that when you're breastfeeding, that is hard work, That is like really hard work. So it means that the breastfeeding mother also has to take care of themselves. So she has to eat like 6 meals a day. She has to drink a lot of water. She needs to eat breakfast snack, lunch snack, dinner snack, because every time she breastfeeds, she would waste like about 400 calories. So hence, breastfeeding mothers, they lose weight really fast. So they go back to their pre-pregnant state very quickly versus the mothers who did not breastfeed. So that's a good thing for persons who into fitness, all right? Now, introduction of the solids. Now, there's a reason why we say don't give the children food before 6 months. And I know people want to stick in a little flower pop, they want to stick in a little piece of mango, all kind of thing you always be giving these children, but you got to be careful with it because it goes back to what they were talking about, which is the NCDs, the non-communicable diseases. So studies would have shown that babies who have introduced solid foods before 6 months are more likely to develop chronic diseases. And that's because at 6 months, a baby's immune system is stronger, is more developed. And if you introduce feeds earlier, their risk for developing diabetes, particularly diabetes and obesity, is much higher. So be aware of that. But I didn't even say the main thing about breastfeeding. For breastfeeding, you know we like to talk about who bright and who don't, right? Breastfed babies actually generally have a better IQ than those who don't. So I added pointer. I see we have somebody here who could have a next baby. So an added pointer is that if your child is breastfeeding, the chances of them performing well in school is very high. So we need to encourage breastfeeding, all right? Now, I put here encourage drinking water, but take note, if you're breastfeeding, there's no need for water. Breast milk has about 87% or more of water. So there's really no need for water if you're breastfeeding. So, you know, mothers ask me that a lot, and I tell them no, and then they get a little worried. They're like, really? I'm like, no. Breast milk, if you were to express milk and you put it to stand, you'll see a whole set of water and a little bit of fat. So you don't need water when you're exclusively breastfeeding in that first 6 months. However, once you hit that 6 months and you start to give your little mango and your mash provision and things like that, and the flower pop, which I don't like at all, right? Then you really need water. And why you need the water at that time? Now you're starting to eat solids, so it means that your bowels now have to adapt to that, and you want to make sure there's enough water so that your bowels stay nice and clean, you have good bowel movements, because the babies who do not drink water end up with constipation. So you have to add in the water at that point. Now, we should eat what we grow and grow what we eat. So the children start to grow up now. So they start incorporating the feeds at 6 months. And, you know, parents would say to me, well, you know, Dr. Donald, the child don't want to eat no vegetable, none whatsoever. So I'm like, well, how the child know not to eat vegetable? I say, how? Right? The child could only know what we taught them, right? So remember that we have to eat what we grow and grow what we eat. So what that means is from the time your child hits 6 months and you start to incorporate the foods, right? You give them a little provision, you give them a little carrot, you grate up your carrot, right? You give them a little bit of mango, because once you start offering them, they're learning it and they want it. But obviously if you didn't give them, and then when they reach about 10 months, then you're like, oh, the child don't want none of this thing. Obviously they don't want it, they don't know it, right? Exactly. So we need to teach the children to eat what we grow, all right? Because all of my colleagues spoke about healthy nutrition. All of them spoke about eating the right thing. So meals rich in sugar, salt, and fat. Now, parents ask again, at 6 months when we start to feed the baby, so we start to give solids, they want to know, I should add a little sugar, a little honey, you know, you have to season up the food. No need for that. Everything in its natural form. So remember, you start training a child from 6 months to drink mango juice. You blend your mango, add some water, and you're good to go. When you go and give them mango juice at a year with a teaspoon of sugar, they don't want it because they're not accustomed to that taste. So we have to start, you see how early we have to start training to eat healthy. So if we start from 6 months, by the time that child has grown, they'll be fine. They must be taught the importance of eating the vegetables and the fruits. Back to eating what we grow and growing what we eat. The snacks. Now we have the snacks and we have the healthy snacks. But children, they like all the bad snacks. The conkles and I like tamarind ball, but the conkle and the tamarind ball and things like that they like. But snacks are okay, but we have to have healthy snacks. So you can have things like, now you have like your fried plantains, right? You have your fruit bowl, all right? So we have local things that we can give our children as snacks. I'm actually beginning to see a lot more parents giving their children cricks. So you see them snacking on the little cricks, which is much better than eating conkles. So we want to make sure we stick to the healthy snacks, fruits, sometimes a little yogurt, a little fried plantain and so, things like that would be much better than doing the processed snacks. All right? Now, immunization. This is a topic of controversy. All right? But immunization or vaccines are important to help prevent childhood diseases. And I'm going to break it down for you to understand why. Now, diphtheria, right? Diphtheria is a disease that I never saw in my whole career, right? And the reason why I never saw it is because most of us in here would have gotten the vaccine against it. So what happened is, over many years, we built up immunity, and now I've never seen one. So if a child presented to me with diphtheria, there's a possibility that I may miss that diagnosis because I've never seen it thanks to vaccines. Now, whooping cough. Whooping cough is another one of those diseases, childhood diseases, that we hardly ever see, right? Every now and then you might have some breakthroughs with it. But again, because of so many years ago, persons were vaccinated against these diseases, we don't see them. Tetanus. I have never seen a case of tetanus in my entire career. So if a patient were to come in front of me with tetanus, I might think of it, but I've never seen it. And medicine is a lot of repetition. Then we have hepatitis B. Now this one is a virus that affects your liver. Now your liver is very important for metabolism and blood and a lot of different things in your body. So if your liver fails because of an infection in it, then you fail. So it's important to have your Hep B vaccine. So even adults get their hepatitis B vaccines, particularly when they're going off to university and so. The H influenza, that one is it's a bacteria that causes tonsillitis and pneumonias, air infections. Again, we don't see much of it because persons have been vaccinated and protected against it. Polio, well, adults, I'm not sure if anybody in here have ever seen a case of polio, but I've seen persons who had polio, but I've never seen a case. Measles, mumps, and rubella, that's 3 together. Again, protected. We are protected against these. So vaccination has shown that it can help because as a result of it, we have not been seeing any of these diseases over many, many years in Grenada. So we're speaking about a lot of prevention and we're speaking about, nutrition, exercise, and all of these things. But in children, everyone who has a child in their household must have certain things in their house. So whenever I see a patient for the first time, I tell them the things they need to have in their house. So basic first aid. So you must have a little first aid kit. Children, they're going to jump, they're going to run, they're going to fall, they're going to bruise. Because, one, if your child gets a burn, you're supposed to know what to do, right? A child gets burned, what do? We run cold water over it. Wet a towel, wrap the child, and you go to the hospital. Of course, that's if it's a big burn, but if it's something minor, you run your cold water. If the child falls off the bed and hit their head, you ice it one time. And you monitor the child. When I say mental status, you monitor the child's behavior. Is the child behaving the same way? Is the child sleeping a lot? Is the child very irritable? Is the child vomiting? If you see any of these things, then you know you need to go to the hospital. All right? Now, if the child receives a bruise, there's nothing like soap and water. We have all kind of fancy things to use now. We have betadine, we have hydrogen peroxide, all sorts of things. But simple soap and water, you clean the wound, And if you have a little antibiotic ointment, which is always good to have home, there's the most common one is Bactin, right? So if everybody should have at least a tube of Bactin home or a triple antibiotic, the child gets a little bruise, you clean it, and you apply your antibiotic. Now, if your child gets a shock, they like to go and, inquire what's going on the wall. They go and they get shocked. They pitch on the other side. Well, you run into the hospital one time, right? You can't wait with that one. So what you need to have in the house all the time, you must have a thermometer. So this thing about, I feel the forehead, I think the child have a fever. Now, remember, we live in the tropics. Grenada is hot, especially these days. It's real hot. So you have the child in a onesie, a monkey suit, a hat, and socks. And then you tell me the child have a fever. So the problem there is the child well-clad, so the child must be hot. So we have to now take off all the clothes and then take a thermometer now and check to make sure, is this really fever or is this that the child is just extremely hot, right? So we always have to remember where we live. So a thermometer is important to have home when you have children. You must have a little box of Band-Aid, and preferably the pretty ones, the one with all the little cartoon characters, Coco Melon and Peppa Pig and these kind of Band-Aids. They'll be putting Band-Aid on for the whole day. So you have to make sure you have enough. So make sure you have Band-Aid. You must have fever medication. There's a whole array of fever medication. You have Panadol, Tylenol, ibuprofen, but you must have these things home, right? Antibiotic cream and the nose drops. Children always get sick in the night. It's a weird thing. It's a weird phenomenon. They get the fever in the night, then you ain't have no medication, you're going to casualty for a fever. Now, well, on another note, a fever, contrary to what we all think, right, is generally not a reason to go to casualty. Except there's fever, extremely high fevers associated with other things, maybe like a seizure or something else. So with a fever, the first thing you do, and we'll talk about that in a little bit, take off your clothes, give the child a bath, bring down the temperature. But you don't go to casualty so that they're going to do that and give you Panadol. You're going and waste time, you understand? So we have to try now, make sure we stock up with these things, your little Panadol, your Tylenol, a little antibiotic cream, so you can manage these little things at home and not have to go and waste hours in casualty. Managing the fever. So the best way is using a thermometer. All right? Of course, I would say as a parent, you must know when your child have a fever or not because you know your child's body temperature. But what is fever? Now, fever, I always, challenge the junior doctors on this whole fever thing. Everybody know about fever, but when you ask them to define what fever is, it's always a bit of a challenge. So fever is considered a body temperature that's 100.4 degrees or more, which is core body temperature. So if I were to take the temperature in the rectum, it's 100.4, we consider that a fever. But if you did it under the arm, maybe a 99.4 would still be a fever, right? What do you do? As I said, take off all the child clothes, all right? And put them in a tub of water so they could cool down. Ice water, hot water, or room temperature water? Which one we put in? Right, so I'm happy to hear that. Room temperature water, right? I know none of y'all going and lie down in cold water when you have a fever, right? So let's not do it to them children. So place a child in a room that's well ventilated. So you can put on the fan, you can put on your AC, right? Make sure the child is cool. Give them the bath, but water at room temperature, right? You sponge them, you put your little wet cloth on the forehead. All of these things can work. And then, of course, you use your medication. Now, first of all, diarrhea, gastro. We all call it gastro. Now, gastro in its acute phase, so when you have acute gastroenteritis, it can last between 3 to 14 days, all right? So sometimes parents would come to me and say, oh, Dr. Donald, this is like a whole week and the child's still having diarrhea. I say, okay, well, assess the child. There's no dehydration. The child is okay eating, no fever, doing okay otherwise. I say, okay, well, we're not worrying yet. We're going to watch it until 14 days. And if at 14 days we find this thing going on from some days after that, well, now we have to go and assess the situation. But within 14 days, it's expected as an acute phase of diarrhea. Now, apple juice in the fridge, right? A little coconut water in the yard, you could go and pick a little coconut and you give the child that to drink, right? Until you could go tomorrow now and buy the Pedialyte or the oral rehydration sauce, which is the ideal thing for that, right? The Gatorade, note well, Gatorade are for the older children, the teenagers, not for the babies. And that's because it has a very high concentration of yogurt than if you didn't. Vomiting. Say nothing. Don't ask me if I could drink, I'll give the child a little water. No, nothing means nothing. Absolutely nothing for 2 to 3 hours. Now, let me give you a little story about this vomiting business. Vomiting is a thing that it causes spasms in your abdomen. So it's like spasms going on in there. So if you vomit and you drink again, with these spasms going on, what's going to happen? You're vomiting again. So you have to rest about 2 to 3 hours, sometimes even more. In hospital, we call it NPO, nothing by mouth for long, because you're on drips. But if you're home, we say 2 to 3 hours, nothing by mouth, and that is just so that those spasms could settle down a little bit. And once it's settled down, you start with, notice, clear, I didn't put here, but cold, clear fluids, right? So, clear. Clear means you can't give something like a smoothie, right? You have to give something like coconut water, apple juice, water, that type of thing. Clear fluids. And when we say graduate as tolerated, it basically means, now if the child had, let's say some coconut water now, right? Then maybe the next time you have a little mango juice, you realize it's a little thicker now, so you could move up until you go back to your regular diet. So you start clear first, and then you graduate up toward your normal diet. But you can't just vomit and go and eat KFC, or you can't just vomit and go and do a smoothie, especially if it's a peanut punch. That's the worst thing you could do. So remember, clear fluids. Clear means you could see through the glass, all right? So I'm wrapping up now, so I'm just going to talk a little bit about what's happening now. So what's happening now? We have number one, viral illnesses. So we have a little hand, foot, and mouth outbreak going on. So a few children well coming down with hand, foot, and mouth. And what is hand, foot, and mouth? It's a viral infection. You get a little fever, and then you break out in a rash. But the rash, you see it you see red spots in the palms, under the feet, and you see rash around the mouth and any other part of the body. But the typical thing about hand, foot, and mouth is that it affects hand, foot, and mouth. But it could affect any other part. All right? So we've seen a lot of that in these days. Now, the thing about hand, foot, and mouth is highly contagious. So if you're here in your child daycare or in their preschool that somebody have hand, foot, and mouth, you better keep your child home. Because within a few days, the whole daycare or the whole preschool will be done with it. So they've had to close a couple schools and preschools and daycares because of hand, foot, and mouth. But it's actually a viral illness, so you can't do anything about it, but just let it run its course. All right? And maybe you could use little creams like calamine to help soothe it, to help dry it up, but you don't really give it any treatment. You let it run its course. Then we're in flu season now. So we call this season after carnival, it's the after carnival cold. But from now until all up to the end of the year, we have flu season, and it even goes into the early part of the asthma, and we having a bit of gastro related to sometimes the flu as well. So that is all for tonight. Thank you very much.
Thank you very much, Dr. Donald. Well, we have heard from 4 doctors. 3 of them gave us a lot of reasons why we should visit our physician. 1 gave us tips not to visit your physician. Unnecessarily. So we have come to the end of the presentations. Before I open the floor for questions and comments, and of course answers from the experts, I just wanted to make a little observation. I have heard through all 4 presentations exercise, diet and nutrition, lifestyles. I heard some culture, ethnicity, visit physicians, and managing conditions. So there is a link through all of what we discussed here tonight. And I do hope that we paid attention, because when we leave here, the rest is up to us. They gave us the information. We're going to ask them questions to clarify the ones we not so clear on. And we're going to leave here making that change from the moment we step outside. So the floor is now open. I have some questions myself, but I'm going to leave it up to the audience first.
Sorry, Ms. Benoit. Before we open for questions and answers, one thing I want to say, I commend you all as a community or whoever would have organized that for whatever you all would have put on here tonight. And I really hope this sets a trend for other communities as well, because those are the things that we need. We need the information to get out there. We need people to be aware, because that's the only how we would prevent, how we would educate people and so on. So I really commend and hats off to you all.
And we have a little trivia. So everybody was listening attentively, everybody nodding, everybody smiling. So we're going to have some little questions. So each one of us get to ask the crowd a question, because we have some little tokens to give out. So each one of us is going to ask the crowd a question. If you answer correctly, you get a token, right?
You all hear that? I should have told you all before to record. Right. So hopefully you can answer their question maybe after they answer your questions. So the floor is now open. Just show by a raise of hand, and there's a mic at the middle there. You can just step up there and ask your questions, and they will remain seated. I think they will prefer if you direct your question at whoever you want to answer. So if it's something on childhood conditions, you would direct to Dr. Donald, etc., etc. Okay, the floor is open. Yeah. Okay, step up.
This is to Dr. Joseph. He spoke a lot about hypertension, which is high blood pressure. What is the case with low blood pressure?
Thank you very much. Okay. All right. So yeah, there has been, some confusions. A lot of persons walking around saying that they have low blood pressure. Just to give you a general understanding, women and younger children tend to have lower blood pressures than regular adults. But for us, medically, what we consider low blood pressure is when the blood pressure is under 90 systolic and under 60 diastolic, and is usually associated with specific symptoms such as easily fatigued, you feel weak, and that's when it's of concern to us. But most blood pressures are usually above that range, and if not, you have to seek medical care as to why that might be happening. Right? But generally, persons they have a misconception of what they think low blood pressure is, and for that, it's a blood pressure that's absolute, below 90, 60. Okay? I hope that answered the question.
Thank you, Dr. Joseph. I think I saw, was it Dr. Alexis?
organizing of this session is to be highly commended. Now, COVID has forced us around the world to ask the question, to what extent must the law work hand in hand with medicine to deal with communicable diseases? Has the medical profession in Grenada begun to address that question? Can the privacy of the individual override the well-being of the general community in terms of medicine in relation to communicable diseases? Thank you.
So thank you for that question. Now, in terms of the law, I actually like that question because, yes, this is something that we would have to work towards. We've been working on policies, and so that will guide, how we manage identification, surveillance, and management of the communicable diseases. But, yes, we have to work on how does the law play a role in that process. So, Dr. Alexis, that means we can reach out to you for some help in that regard. So it is something that we have to look at. There are laws that guide healthcare in general, but the issue of non-communicable diseases, which is really plaguing us right now, is an area that we really have to see how the law can be applied to that area as well. Thank you.
Oliver? The mic in the aisle.
I have two questions. The first, I'd like someone to address the issue of ethnicity. It appears from time to time that we speak about black people have a higher level of susceptibilities to say high blood pressure and so forth. So I want to address that issue because in my thinking, I want to believe it's who actually present that data and what they're looking at. So I think one has to address that carefully because I am not sure that one could say that in all cases we see, say, black people for that matter with a higher level of hypertension. So I want you to address that issue. The second point relates to healthcare, primary healthcare. You talk a lot about what people should do concerning their health. When is the hospital system focusing on community health where doctors and community people can interact with the population in the community like this, not the way we're doing, but in connecting to people in their homes to address certain health problems through community health care rather than relying on the hospital system? Because if we were to do what you said, you probably would not be able to cope with the amount of people that will come to you. So what about looking at it and the other way around? Addressing the issue from the community, particularly primary health care, community health, and connecting with people at their homes rather than, asking people to come because we know it's not going to come. And added to that, the question of the social issues concerning health. I think that was mentioned. But if there isn't a serious program to address social issues, we're probably not going to solve the health issues in the country. So how do you address those issues?
Well, I want to respond to the last two issues I would have mentioned. Okay? The first one with the non-communicable diseases and so on, especially like in blacks and so on. I think there are a number of studies, that are internationally accepted by the WHO and so on, that shows that especially Afro-Caribbean and Afro-American blacks are at more risk, even when compared to the original Africans, and so on, when it comes to the non-communicable diseases and so on. There are a lot of different theories, not necessarily concrete yet. A lot of theories, and maybe Dr. Joseph could give us a little more insight to that, as to why Afro-Caribbean and even Afro-Americans suffer with things like diabetes and hypertension more than the other ethnicities or the other racial groups. What I want to speak to, you would have made mention of the hospital and the doctors reaching into the community, but I think that should be at a governmental level in terms of the policies that they set. You know, policies have to be set where primary health care is given that sort of importance. Once you reach the hospital, you're talking secondary level of attention already. Hospitals deal with more complications and so on, and a disease that would have been there for a bit and is basically advancing. Yeah, at the primary level, when it comes to decentralization and when it comes to the information being spread, or when it comes to being health facilities and so on being accessible, when it comes to even integrating schools and all of those things, I think that lies at a governmental level to set the policies in place. I know Dr. Donald wants to share as well.
So I really like that question regarding primary health care. Now, first let me say that I guess even going way back to the revolution, the time of the revolution, Grenada actually has a very good setup in principle for primary health care. So within Grenada, there is a medical station or health center, I think within every 4 miles. So within 4 miles, you can get either a medical station or a health center. Now, in Grenada, we have let's say the infrastructure, the proper setup, all right? But over the years, honestly, we've had some challenges, and primary health care right now needs to be revamped. Now, healthcare is actually one of the priority for our government right now, and of healthcare, primary healthcare is actually one of the top priorities within health in itself, because the infrastructure is there. We have challenges with our human resource, because I know you may have known that we lost quite a number of our nurses, and so we're challenged in terms with staffing and so on. But within the Caribbean, Grenada actually in principle has a very good model for primary health care, but right now it is not functioning as best as it can function. Now, one of the things let me talk about the good parts of it. So in terms of maternal health in our primary healthcare system, that functions very well. So the antenatal care for the pregnant woman, that functions very well in our communities. In terms of child health, it also functions very well. In terms of the vaccination program and so on, that functions okay. Then there is a school health program. So a few of the physicians from the community or the district medical officers, they go into the schools and do screening for the children, and so that's been happening. You may not have heard much about it or seen it being, on air or anything like that, but that's been happening. So you have the school health program, which was revamped, and it's actually happening. Of course, with COVID, a lot of things went on pause, but these 3 areas, I could say from where I sit, these are 3 areas in our primary healthcare system that functions well. Of course, there's always room for improvement. Now, in the area of non-communicable diseases, we had a program with chronic disease clinics. And of course, during the pandemic, it went a bit on pause, but we're now trying to revamp these clinics. And so again, the chronic disease clinic where persons with the diabetes, the hypertension, and all the other chronic disease go for follow-up. So our primary health care needs a bit of revamp right now, but those three areas I mentioned are areas that it functions well. But in the areas of the non-communicable diseases, the screening, the surveillance, managing the persons with the hypertension, the diabetes, so that they don't come to us at the hospital with the complications, that area definitely needs a lot of area for improvement. So I really like that question because it's actually a priority for us, and it's something that will be worked on. Those three areas work well, need to be improved, but we need to do a lot of work for the NCDs.
I'm not sure I heard anyone answer the question about the ethnicity. And I must say that that is a question I had as well, because I have been wondering the same thing. Is it a matter of who does it? And let me just give you one example. I worked in the health sector as well. And I recall sometimes doing health fairs and so. And you see some tall, slim people come and then they tell them they're overweight. And I'm saying, okay, you need a black people chart because this overweight is by somebody else's ethnicity. So yes, I would like to hear that one addressed just before we take the gentleman.
Okay. Well, if I understand the gentleman's question correctly, it was met with some level of skepticism as to black individuals having more prone to hypertension, diabetes, and even based on studies that showing prostate disease and having higher mortalities. Right? These studies have not been done by just a uniform organization. They've been done by our healthcare leaders, right? WHO, which are regional organizations and international organizations whose sole purpose is to try to, and PAHO, which is I think our regional organization as well, to try to give stipulated structure and guidelines to help lower and middle income countries to improve their healthcare systems and combat these diseases despite being resource limited. So at this stage, there's no clear indication as to why there would be false reporting or any studies that would have been manufactured to say that we have more disease, why we need to combat this. Because the way to combat these communicable diseases, main thing is lifestyle changes and adherence to their medications. Most of your high blood pressure medications and diabetes medications, because of how widespread the problem is subsidized, and so it's available at a relatively low cost to most countries. So I understand the skepticism, but it's been founded by many research and articles that can be traced and verified with these organizations. I don't think I have anything else to add.
Race as an issue. So there's the underlying racist implications there that we must pay attention to.
So let me address some social ills. So with social ills, it is harder for persons with lower incomes to be able to afford the fruits and vegetables that we want, right? It's harder to, gym memberships have a cost, right? There are a lot of things that would make living a healthy lifestyle a bit more difficult in lower income countries, right? We have individuals like bread and making bakes making bakes is usually cheaper than buying bread, right? And we know that bakes is a higher calorie meal, but it's easier for a lower income family to do, right? It's these ills that are and these disparities that make it difficult, and we understand that it contributes to health, but we can only advise. It may be one of the major factors contributing to our higher rates. That cannot be said absolutely, but these research, what they show is what's there. Not what we like, but what's actually there. We'd prefer it not be there, and prefer it not be part of our reality, but that's what exists in, and we need to advise you of it. It's hard to say there's a causal relationship. Just because a pharmaceutical company makes something that works and it's profitable for them doesn't mean that it's not good. It's the same way. It's the same way that you know, everything is not useful. Okay.
Sorry, just to add one thing. I don't think it's a fair statement to say that those things are there. It's not like I don't think it's fair enough to say that, or fair to say that those things have like a racist motive. Is what is there? Okay. Okay. Well. Yes, yeah. But a lot of those things have to do with genetics as well, genes and all those things. There are other components that we have to evaluate.
Because I need to qualify that, because I think you placed a lot of importance on ethnicity, and it's just it's one of many major risk factors that contribute. It's not a causal agent, right? There is no study that has published and said, because you're black, you're hypertensive. No. What the studies have found is that blacks have a higher propensity, along where you have more major risk factors, your chances increase. Obesity is a big risk factor, whether you're black, white, Asian, Indian, right? Older individuals, age. If you have, you don't have a proper exercise regimen, if you're a white smoker, if you're an Asian drinker, all of this correlate and contribute to the disease process.
And so on that affects other races just as much. For example, skin cancer affects whites much more than black individuals, and that is not based in, you know, even to the original Americans. There's this study showing that the normal HbA1c levels are generally higher than the other ethnicities and so on. So those things are based in evidence more so than anything else. You know, the studies that is not because of, yes, socioeconomic factors and so on do play a major role in all of those things, but those studies are based on research, and most of they're factual.
Yes.
Yeah, good night. Good night. Good night to the panel. Thank you very much for very informative and comprehensive. Suggesting that kids should be vaccinated for COVID. In your professional opinion, do you see that trend following suit here in Grenada, and what is your recommendation? That's the first question. The other question has to do with the cancer, prostate, and cancer in general. Now, I listened to the panel, and you presented risk factors and what we should do not to get it. I didn't hear much about what we can do when family, friends, ourselves actually have cancer. whatever it might be. And I know that cancer changes people's lives. There is psychological, social impact, and then there is a cost factor to deal with treatment, especially in our part in Grenada and in the Caribbean in general. What are some of your suggestions for coping mechanisms, not just for persons with cancer, but loved ones and families, how they should deal with this? Thanks.
So thank you for those questions. And I was saying, I wonder if I'll pass this night without a vaccine question. Yours coming next? Okay. So in terms of the COVID-19 vaccine, so that, well, let me answer the second part first. What would be my recommendation? Now, my recommendation for that vaccine for children would be, I will recommend that children get it, particularly children who have underlying conditions. So, for example, our sickle cell patients, our diabetics particularly, our asthmatics, these are the patients who are at high risk of developing severe disease for COVID-19. So I would recommend, based on the cases I have seen during the pandemic within Grenada, though Grenada did not have many pediatric cases, severe pediatric cases, we did have a few patients who developed COVID were admitted, and most of these patients were actually the ones with the underlying issues. So it shows that persons with underlying conditions, particularly the ones I mentioned, sickle cell disease, asthma, diabetes, these are the patients who are at a very high risk of developing severe disease. And so I would recommend, so this is now my personal opinion, I would recommend that these persons should be vaccinated against COVID-19, because if they do get it, particularly the diabetics, their risk of developing a severe form of the disease is very high. Where do we want to go with that? I know the Grenada, actually, we did have the COVID-19 vaccine for the younger children, and the uptake was not good. It was not good at all. But I guess it requires educating our public, continuing to educate. Persons are a little bit more skeptical because you're dealing with children. But the strangest thing about this is that the kids can also develop severe disease with underlying conditions. So for that reason, we recommend it for the children as well, and it was actually being offered, but our uptake was not good. So our EPI unit, which is the department within our ministry that deals with vaccination, immunization, they actually had that vaccine on stock. But our uptake in Grenada was very poor, well, just as with the adults. So it was very poor, but I would recommend it because I've seen what it can do to children who suffer from underlying conditions, particularly the diabetics and the sickle cell patients and the asthmatics. These three, they're very high risk, and they can develop very severe disease. Even the children who have lupus, because we have children with things like lupus as well, they are very, very high risk for developing severe disease. And these were the ones who actually developed severe COVID-19 disease during the pandemic.
Yes, so to address the question of how we support patients and their caregivers, family members, when there's a diagnosis of cancer, which can often be distressing for people, there are many lines of support that are offered. So for those who need, first of all, just to sit and talk with it, many of the staff at the oncology unit, they are very supportive, extremely supportive. They have teaching sessions, and there are people who can be called whenever you have a question or a doubt about your condition. If there's some symptom you wish to discuss, you call one of the senior nurses, you call me and you speak, and we ask you to come in and we discuss with you, okay? So any symptoms that you might have, any concerns that you may have, you may need documentation or letters to be written to local entities or to persons abroad. We're there to help you with that. If you have disorders of mood, for instance, and you need to speak with a psychologist, we can refer you to such a person, because there are some people who can become very discouraged. So any sort of help that you need, for instance, speaking about your diet, we can also give you some advice and some counseling there. And we're just there to speak with you all through the process. If there is some service you need that we don't offer in Grenada, we can refer you to service abroad, outside of Grenada, and help you to get all the planning in place so that you can travel. And for instance, radiotherapy, we're there to help you with that, find places where you can go in the Caribbean, in Antigua. Other people prefer to travel to Trinidad or to the United States of America. But at every stage, we're there to help you along the way. Some people may have mobility issues and may need to have blood tests taken in the community before they present for clinic for chemotherapy. And there are often people who would help you with that. Right here in St. Paul's, we've had that done. And in other communities, there may be a nurse who might visit your home and help you. So you're not left to go through it on your own. We are there to help you at every step of the way.
I just wanted to add to that as well. So we also have the Grenada Cancer Society, who also work together with the oncology department to give support to patients. And we recently launched the Grenada Cancer Portal, which is online, where persons can do questions and answers. So this is the Cancer Portal was recently launched, so it's something that persons can also look online for.
Okay, next question. Mary, okay.
Yes.
So get in line.
Doctor, let's just one quick. The number for the oncology unit, could we have that? Because if you say that they provide that kind of advice, yeah, I think it would be important if we could know contact number or maybe emailing address, whatever. Online, you just step online and you will find it.
We can call the oncology unit at 435-1976, and there's somebody there who will answer you. Thank you. You're welcome.
Good evening, everybody. I'm very thankful for a forum like this where I get the opportunity to solve, put my queries at ease. Because for many years, I'm hearing about this. I don't know if it's a myth, so I'm here to, put it forward. Now, first question goes to Dr. Batiste. We speak about the X chromosome and the Y chromosome. Could there be a mix-up between these two chromosomes? And what could the result be?
Well, there are certain syndromes and so on. For example, like Klinefelter syndrome and so, where we have someone having two X chromosomes and a Y, but it's the person would, in that instance, would still be considered masculine because they have the Y gene. And then you have other conditions as you have quite a number of syndromes where
what we call antipa. And I'm happy to hear that the school program is going to be revamped. And I think, because we have so many delinquent parents, so that we need, to have this going so that the children will be looked after. I myself, when I want to call math and things, so I put myself in the group for the antipa because, I want to call math. So I want us to look at that program so that we have, the children who really need the care and, they have really delinquent parents. Thank you for a good program.
Good evening. My name is Fluz. Some of them have become more or less extinct. In today's vaccination of babies, do you still vaccinate for these things that no longer exist?
Yeah, I think that's a very good question. So, yes, and I'll explain why. Because, for example, what we've noted is that over the last few years, we've had a growing group of persons who are anti-vaccines. So, because of that growing group of anti-vaxxers, what has happened is that it has given a little, made a little bit of a, a little weak area with measles. And then, there was the issue of the polio recently. So, and this, of course, is happening because there's growing groups of persons who are not in favor of vaccination. And, of course, these persons now will put other persons at risk. So, yes, we need to continue doing it because, of course, over the years, you can have mutations, you could have changes in strains, and, so you want to make sure that persons maintain their immune system prepared to fight against these illnesses when they re-emerge.
Good night, particularly to the doctors, and excellent presentation. So my question is, in this era, the digital era, where are we with digital records, medical records? And secondly, I kind of asked that because I know when I was younger, I had a doctor. The doctor died, and I don't really know what's become of my medical records. So I don't know if that's a question that could be answered as well. And I know probably with the intervention or with the advent of the digital medical records, something like that may not be a concern. Thank you.
So I see who's a techie person in the room, and very, very good question. So in our health system, we've actually started the digitalization of our system. So in the community have an electronic medical record system. Now that system, there are plans to roll out to hospital as well. But within the hospital, we already have a digital system for our lab and for X-ray. So that already exists within our hospital. So that's digitalized. The records, we're not there yet, but it's one of the things in our plan to do. So in the community, it works well. So they've rolled it out. They're using the electronic medical records. That's happening a few years now. They've been using that system. So it's just now for us to work toward rolling it out in our hospitals as well. But within the hospital system, you do have X-ray and lab that's already digitalized. So that's a very good point because now with the whole lab and X-ray system, we can now go and track back 4 years ago results for persons and look at trends. And it's so much easier than having to deal with the whole paper trail. So this is another priority for us to get into the electronic medical records and try to map it so that the persons in the community health system will also have access to what's happening in the hospital and vice versa. So that way a person's record follow them through.
Good evening, doctors. Thank you very much. I have 3 questions. One for Dr. Donnell and Dr. Battiston. One, do you think there is a need for the re-education of our boys so that we don't have this continuous, I don't want to use too much of a harsh word, but seeing our men go down the drain like that, socially, with their health, with everything. That's one, and how it can be done. 2, is testing for HPV done in Grenada? And 3, I would still go back to the gathering of information and the results we get from the CDC in America and that sort of a thing. Is there an organization in our hemisphere that does that sort of collect these data and do this sort of a thing for us? Even in Grenada, where we're seeing so many cases of cancer, is there an organization here, a group of doctors or researchers from the Caribbean, doing any studies to give us, something that is for us in the Caribbean. Thanks.
So I'll answer the last two. So in terms of HPV testing at the hospital lab level, no, we don't do the direct HPV testing at our lab in the hospital. In terms of the gathering of data, now gathering data, a lot of that is taking place in the Caribbean now. It's done through the different organizations. We have the CARFA, which is the Caribbean Public Health Authority. They based in Trinidad. There's also an office in St. Lucia. They collect information from all the islands. Even through the OECS Commission, they have a health branch of the OECS, and they also do a lot of studies, data collection, and so there's a lot of collaboration now trying to get the islands to standardize so that all of the islands, like more or less, we're doing the same things, following the same policies, using same equipment. So there's a lot of data collection taking place right now. I mean, in the Caribbean, that's a big problem, data. So if you notice in the presentations, you would see that when we refer to data, a lot of the times we refer to what's in the US, what's in UK, because their data is readily available. In the Caribbean, we know, I think with the whole IT and using information technology, we're trying to improve on that in terms of data collection. But yes, we have an EPI unit in our Ministry of Health, epidemiology unit, that collect data for Grenada. So at the end of each year, they're able to tell you the top 10 causes of death. I mean, just to note, for last year, number 1 was COVID, number 2 was cancer. So it was cancer as number 2, so technically is number 1. So we have to be mindful of that. So we have the EPI unit, we have CARFA. CARFA, we send, all of the islands send samples and information to CARFA, and there's a reporting system. Then we have the OECS Commission that has that health branch. They also collect data from all the OECS member states. And then, of course, we have PAHO. So there's a lot of reporting that takes place within our ministry that is sent out to these different organizations. So hopefully, maybe in the next few years, we will have a little bit, will be improved in terms of the data that's available for the Caribbean, because there's been a move to try and collect data so that when you go online, you're not just seeing US, you could see US, Africa, Caribbean.
To respond to the question as if we should undergo a system where we have to re-educate our boys, I would think that yes, at some point we have to start having that discussion in terms of the way we because in the Caribbean and in Grenada, we have this kind of tough love mentality for boys, basically, and we've seen where it leads. A lot of we saw the statistics and so on, a lot of them end up in prison, they make bad decisions and all those things. So we have to have the conversation, and we have to take on policies that would be directed specifically for boys' health and men's health on a whole. Yeah, so to answer the question, I think yes, we have to start with a re-education process.
And I would even go further and say that the education process actually starts with us right here. Definitely. Because it's generally with these things, it starts from home, so we have to change that mindset. 15, maybe 18 females and 2 males. Yes, and it's a constant trend. In most of the trainings that I've attended, you see a whole set of females, you see less males, and it's always less than half. So it's like maybe a quarter. It's very evident. So I think like this session was a very excellent session, and I think this type of training could start right here with us.
Good night, everybody. And I'm indeed very happy that I have attended this session here tonight. I want to commend the committee for organizing this session, and also you, the panel. Tremendous presentation. And so I think we all should be in a better place so that we can live a better quality life, because I think that's critically important. Now, I want to ask a couple questions and also make comments. First, I will start with Dr. Joseph. Speaking on hypertension, I know that you did not mention anything with regard to magnesium, calcium, potassium, even vitamin D, and drinking of water, which can all impact on your blood pressure. I'm a layman, but that is what I know. So I just want to ask how critically important those things are to maintaining a good blood pressure level.
Good night, and thank you for your question. These electrolytes are critical for your overall health and functioning. It's not just applicable to hypertension. It's also applicable to all diseases. So usually, if you're not getting a well-balanced nutrition, we as healthcare providers would advise that you get a vitamin supplement, or you find other ways to make sure that you're getting the recommended intake of all these micronutrients and all these electrolytes. So it's applicable to all diseases and very important, right? Okay. So even though you're doing your lifestyle changes, including the stopping smoking, limiting the alcohol intake, your diet improves, you can add supplements as well as take your medications. Right.
May I just add to that? I don't want us to have the belief that we need to take in those things as supplements or whatever the case may be. Those are what we call trace elements, most of them, copper as well included, even zinc and so on. Right? If you maintain just a proper diet would give you enough of those substances. You don't have to, say, consume those things in high quality.
The discussion we had with regard to the advantage socially. Recognizing that free radicals played a critical role in one going down with cancer. And recognizing that free radicals bombard our bodies on a daily basis. That's from my own knowledge, from reading. If we just rely on...
This is in the system. It's a daily lifestyle choice.
Yes. Someone told me that the barbecue, the smoke product, I shouldn't just say barbecue, but smoke products plays a critical role in one going down with cancer, especially something like breast cancer. Is that really so?
So think material that is roasted like that, so that's why we tend to avoid the barbecued food. Yes. And I know some people are even concerned about things that we use here traditionally, such as the roasted corn, yes, because carcinogens are generated when we eat food prepared that way. So it's probably wiser to stay away from food prepared that way and use boiled food.
Right. Okay, thank you.
And just at that point, the Japanese, based on studies, they normally eat a lot of the smoked fish, and they suffer with a lot of colon cancer and bowel cancer. So just to that point.
Thank you. And the last question, Dr. Donald. You spoke a lot about the children should be given a very good diet from a very tender age. And they should avoid food rich in sugar, salt, and fat. Well, I agree to a certain extent, but with regard to the fat, I would want to say, provided that it's a good fat, like the avocado fat and the proper diet at that age, because that is what would fix our problem that we have today. The government spoke about a new hospital. Yes, we need a new hospital. But that's not going to fix the problem, because the truth is, the hospital is dealing with the managing a disease. We do not want it to reach that far. And so we need to start with the children. But it therefore means that we have a lot of work to do with the mothers and the fathers. So what do you have in mind? What can be done? I guess as much as a collaboration with the Food and Nutrition Council, where they can really have a good program educating mothers or families in general as to how critically important it is for them to ensure that the children get a solid, natural diet at that young age. Thank you.
Okay, thank you for that question and comments. And so I agree with almost everything that you've said related to the diet. So yes, there need to be collaboration. There's already some existing collaborations in terms of the school feeding program. And part of that school feeding program is to ensure that the children get these balanced, healthy meals in the school system. So they come up with a menu. They try to do a proper balance so that the students get what they're supposed to be getting on a daily basis in proper proportions. So there's already a bit of collaboration going on. But as you rightfully said, there needs to be collaboration at a bigger level, because we need to involve the parents. And I'm a pediatrician, and I can say that, it's something I do a lot, because I'm a very strong advocate for breastfeeding. So I spend quite a lot of time to my new mothers discussing breastfeeding and trying to convince them why they should not be eating before 6 months, because it's literally convincing, So that education has to start from that early stage. And this needs to start in the school, all right? So at home, in the school, we have the school feeding program, but not just about feeding the children a proper meal, but also having parents understand that your kids are eating a proper meal in school, but what are they eating when they go home, right? So we have to educate the parents on how to eat. Now, I know the Food and Nutrition Council have done some work over the years in educating the communities, and even sometimes going to schools and so to educate on healthy diets. And they've even done like radio programs and TV programs regarding that. But it needs to be a bigger collaboration between the Ministry of Agriculture, between Ministry of Health, with Ministry of Education. We all need to come together and literally come up with a program. There is there was a project going on, Healthy Grenada, which is in the pipeline. There's some discussions about that, and that takes into consideration, of course, diet, exercise, and all of that. So yes, this is something that we have to do. It's been done let's say maybe not as organized as we would like it to be. It's happening with the school feeding program, with the work that Food and Nutrition is doing, but we really need to embark on that Healthy Me Grenada initiative, which is something that's in the pipeline.
Okay. Thank you, Dr. Donald. Thank you to all the doctors. Now, you asked them a lot of questions. They answered you to the best of their ability. Now, they will ask you some question, and hopefully you answer to the best of your ability, because there is a prize, or maybe more than one. So we're going to win big tonight. So I would ask, which one of you asking a question, or which ones of you? Okay, so let's make it quick, and you want to answer, you show by raise of hand, you'll answer, and you'll be rewarded for a correct answer. Dr. Donald?
Okay, so my question for tonight is, you have a 2-year-old child who vomited 3 times, and I want to know, what do you do next?
Show by raise of hand if you want to answer. Okay, I saw that.
Sheldon?
Wait, hold on, let's regulate it. The hand right at the back was the first hand to go up. Come forward and answer.
Nice.
Good night, everyone. You don't give them anything to eat for the next 2 to 3 hours.
Woo! All right. Come forward to receive your prize. Stress it to the tree. Oh, yes. Okay. The next question comes from, how many questions?
Dr. Joseph.
Okay, the next question comes from Dr. Joseph.
Here we have one question.
Listen carefully, show by raise of hand, and first person to raise their hand will be given the chance to answer.
Okay. Well, my question tonight is, so what is the most common sign or symptom of hypertension or high blood pressure?
That's right. Mr. James? Yes?
Dizziness?
Nope.
No. Let's try again.
Yeah. No, you go ahead. That's
Yeah, you got it right.
Done. Come forward to receive your prize. Nothing. Nice. Thank you. Any of you? Okay. Right. Next question.
My question is, of the leading causes of death among men, what category is the first, the leading? Nope. No. I have to go back to the slides you know.
Any more hands?
What is the leading cause of death among men? Heart attack is a category, not one particular disease. Suicide, no.
Any more attempts? Yes, please.
Cardiovascular diseases.
Come forward and receive your.
I'll make it tough.
I want another question now from Dr. Alexis.
Yes, which agency recommends breast cancer screening for women aged 40 to 49 after the weigh the benefits and the risks? Well, that's a good answer.
Accepted?
Yes.
Okay. So come forward for your.
Yeah, it's the USPSTF, United States Preventive Services Task Force.
Okay. That's it? Okay, thank you very much. Wasn't it an interesting session? Very much so. Next critical question. There's another one?
Can anybody name or tell me 5 things that we could do for healthy living? You have a prize for you.
Show by hand.
5 things to do for a healthy lifestyle.
Come, we need somebody to raise hand and answer. Okay,
Is it 5? 5 is easy. Exercise.
So manage your diet, exercise, your lifestyle change, early screening, and avoid stress. So just add that one, I know.
Very good. Come on.
We have a lot of intelligent people in the audience.
Oh, yes, we're from St. Paul's. Come on,
Listening.
and go. Okay, very good. So, my final question now. Did you learn anything tonight? Yes or no?
Um, I just want to say that I like this crowd, you know. This crowd is a very intelligent crowd, right? And the questions were very good, very thought-provoking, that brought out the information. You know, so it helped to remind everybody of all the things that most of us know already, but it's a reminder. And when you go home, you're going to talk about it, and that means somebody else is going to be reminded. And that way we multiply through. We go in by 3, by 4, by 5, so a lot more persons in St. Paul's going to be living better by January, right?
You skip December?
Also, one take home I want to give. Well, my take home point is that hypertension and diabetes are chronic conditions that don't go away and that are managed with your compliance with your lifestyle modifications and daily adherence to your medications.
Thank you, Dr. Betis. Dr. Alexis? Dr. Joseph, sorry. Dr. Alexis?
Yes, screening for cancer catches it early while it can be cured. So speak to your healthcare provider.
Thank you, Dr. Betis.
Only prevention saves lives.
Thank you very much, Dr. Donald.
Breast is best all the time.
Okay, so at this point, now that we have something to take home, I'll invite Cecil Noel to move a vote of thanks.
Thank you, Madam Moderator. Good night, everyone. Forgive me, just give me a minute. We had some people online because the event was streamed, so I just wanted to highlight some of the comments that came through. For example, from Roxanne Antoine, she said it will be nice if other communities can have forums like these, as it is greatly appreciated. And by the way, she also answered one of the questions, but unfortunately, so I'm hoping we could fix that. She did answer the question about the children. Stay away from feeding them for 2 to 3 hours. We also had a comment from Andrew Font stating how grateful and thankful she is to Judy. Thank you very much for the excellent job in making sure it flowed that it should. To Mr. Thomas for the opening prayer, we say thank you. To GIS, who is here present with us tonight, making sure that they're captured so that it can be used for further education of the general public. Thank you, GIS. And to Mr. Blondell George and Mr. Colin Dragon for making sure we were able to stream the session as well. Thank you very much. And we know there are other people who made significant contribution and input. Oh, by the way, let me just say to Mr. Hugh Oliver, who willingly agreed to assist with the projector and screen and other things, although we didn't use his screen, but he also gave us one. Thank you very much. And again, it just goes to show that when we do things that are worthwhile and have positive impact on our community, just how far-reaching and how much people will be willing to assist. It was the same for Blondell and Dragon. They agreed to come here and assist us. And to all of you in the audience, both here with us live as well on the live platform, thank you very much for being on with us and for being a part of this very important session. Thank you, everyone.
And thank you very much, Mr. Noel, for moving the vote of thanks and for thanking all those who had anything to do with this. Thank you all again for coming and have a pleasant night. Remember to share the word as you leave here tonight. Thank you all.